honor to have you here.
Thank you, Chair and Co-Chair. And good afternoon. And I'm so happy to be here again. And then I would share with all of you with the case of anophthalmic socket. We know the anophthalmic socket is the orbit cavity doesn't have an eye wall anymore. That can be congenital or acquired. The etiology can be by fissuration or enucleation. That's why the anatomical change, including the orbital volume, depletion and periorbital tissue rotation and retraction of the posterior and inferior segment propulsion to the anterior. This retraction generates shortening the fornices of conjunctiva, leading the contracture and decrease the fornic depth. That's why they can get the post-enucleation of post-efficiency socket syndrome. And the prolonged time, the PS socket abnormality can have a contracted socket or laxity socket or even the extruded of the implant or infection. The contracted socket deformity requires reconstruction surgery to enable the patient use prosthetic eye and with a good position and aesthetically. In mild condition, retraction of minimal shortening of the inferior fornices and a moderate, more significant contracture and loss of the tissue in the inferior and superior conjunctival fornix. In severe condition with the contracted, its conjunctival fornices are nearly absent or maybe we obliterate, making it difficult to hold even a small prosthetic eye. And I use in here auricular cartilage graft to apply in the socket deformity correction is considered to have greater support for prosthetic use or longer durability, and then mucous membrane graft, which can be contracted even 30% in 4 months. Hence, with the cartilage can hold out for longer term. The inclusion criteria, I use this technique with in mild and moderate contracted socket. Patient with more than 18 years and without previous surgery before. And the other both side of auricular defect is not had in the patient. Firstly, I would like incision in the fornix area, release the adhesion, and then until the orbital rim, and then I take it the auricular cartilage harvest in Simba concha area. This is in the picture, and post-operative, I give it the ointment and then povidone iodine in the donor area. I evaluate 1, 2, and 6 weeks until the 8 week or post-operative. This is our result. From the 12 case, there are some complications like granuloma in the fornices, but it can be resolved by the eye ointment steroid. And in here we can see before and after the surgery, the inferior fornix depth is more increasing, range for before the surgery is 2.7, and then after surgery 7.1, and the socket volume is increasing with a significantly before and after surgery. And for the quality life score, we check it before and after the surgery, the physical health, psychological, and relationship and environmental. There was a significant difference before and after surgery. This is a photograph before and after surgery. And we can see in here after the surgery, the conjunctiva, the epithelialization very well, and then only a few patients, maybe 2 cases with the granuloma. But after this, after we give the eye ointment steroid, it can be resolved. And for discussion, socket reconstruction was the option expand the fornix depth in patient with a contracted socket. In this study, using the auricular cartilage graft because of the ability to expand the posterior lamellar and support the prosthetic eye with longer contracted time than the mucous membrane graft or the amnion graft. Auricular cartilage are ideal for the contracted socket reconstruction because its shape for the inferior curvatura, thin, smooth, and more flexible. The graft was relatively more stable and from long-term against absorption and contracting and or stretching. And from another study, previous study, the contracted rate is around 9%. If we comparing with the mucous membrane graft is 25%. And the complication in here, I have a complication, but the rate of success is 91%. And from the retrospective study previously, there was a success rate about 86%. And by Smith and Mallet, the fornices reconstructions with the cartilage was have a successfully 92%. And this is my reference. Maybe I can go here if it still have a time. This is when I'm doing the surgery with markering in the fornices and give it the 1 minute. And then I dissected into to the orbital rim again.
Can we have the slide, please?
Okay. Okay. Just continue. Yes. This is I will dissect the conjunctiva until the orbital rim, and doing the cantotomy and cantolysis in the lateral of the canthal, and then put it the conformer first. And here we have a slight entropion, mild entropion, and I'm doing the anterior lamella reposition. Can you do it quickly? After I did the anterior lamella reconstruction for the upper eyelid entropion, I take it the Simba, the cartilage from the earring. Yeah. In case in patient with a small Simba, I think it's not recommended. But in case patient had a Simba more wide, we can use this technique. And then I put it the graft cartilage in the conjunctiva and the fornices. After that, the epithelialization of conjunctiva is good after 2 months. Thank you.